Yeah. Okay. So let me call my panelist, Dr. Maushami, Dr. Bhavesh, Dr. Prashant, Dr. Amit, and Dr. Pratik. Okay. Dr. Pratik has to go for another meeting. That's okay. Can you project the slides? Yeah, I can see on my okay. So yes, so I'm going to keep it very basic. Like as I'm not a molecular pathologist, I'm just a clinician. So which we are better off talking to patients about what is how they are likely to behave than how the NGS machine is likely to behave and how the tumor genomics changes. This is just a busy figure just to show that I mean just about maybe 10 to 15 years ago when I went for interview in Tata, they asked me, would you care if the patient had squamous carcinoma or adenocarcinoma? Would you treat differently? I was thinking, no, I would give paclitaxel to both. So why are they asking me this question? From that time to now, just looking at molecularly targeted therapy alone, we get confused. Like so many drugs, so many trials. How do we position them? How is this player better than the other? What mutations would play a role? And it's getting impossible for clinicians actually to follow up this information. And this is where we need I mean, ideally a molecular tumor board at every clinic, which again is like here we're talking about one NGS for the entire Eastern India, and then I'm hoping for a molecular tumor board in every institution, which is so very difficult. So I just took some of these simple cases. Some slides are from the ASCO meeting, but just to highlight a usual run-of-the-mill patient who. She's a lady who had a persistent cough. Obviously, you can see there is a lesion somewhere in the bronchus and there is a nodule in the lung. So in this situation, many times when we do a biopsy, sometimes the report may just say only carcinoma, poorly differentiated carcinoma. Sometimes the tissue is limited. So the question we have in our mind as clinicians is, or maybe when we send you the sample, do you really want to know what kind of carcinoma is the pathologist calling it? What if it's a small cell? What if it's a squamous? What if it's mucoepidermoid? Does that change the way you?
Yes. As a geneticist and also a practice head, primary diagnosis is very important, and especially based on whatever the histology and the CT and all results. This makes us more specific and a targeted approach whenever we recommend or map a particular NGS one.
So
two questions I ask
is squamous carcinoma or small cell.
Yeah.
Do you still want us to do the NGS on that?
Such a molecular characterization is not required. So a broad classification of saying like carcinoma or adenocarcinoma will help us to do the variant identification and the interpretation level and all. Because then it becomes easier for the clinicians or the medical oncologists to understand the report better, because at the end of the day, the clinical benefit of the report is very important for us and all.
So Bhavesh, do you send NGS even for your small cell or anything which is non-adeno, or you only send for adeno?
So usually we do it for adeno for all of them. Squamous, we try to do it for all of them. Small cell usually I'll not send.
Okay, so this is actually a report I just got last week. It is doesn't belong to the PET CT what I showed you, but it's a 71-year-old lady, frail lady, has been having an endobronchial tumor, which is the history is very indolent, going slowly, just being managed with the biopsy was some carcinoma, probably mucoepidermoid. So the diagnosis was like a salivary gland tumor, and she kept having endobronchial ablation, RFA. Finally, she came to a point where she's progressing and now she needs systemic therapy. And then the oncologist doesn't want to give her chemotherapy. So I said, okay, let's just do the NGS and see. And NGS reports EGFR exon 19 deletion. So, and then when I looked at the VAF, it is 1%. So, Dr. Ashutosh.
Can I intervene? Dr. Ashish, can you hear me?
Yes, hi, yeah, madam.
Hi.
Dr. Maushmi, welcome,
Yeah.
Dr. Maushmi. I can't see you, but we all can hear you.
Okay, good. So, regarding your first question about the small cell carcinoma, so we are doing EGFR, like the routine testing, in case it is an unconventional small cell, a non-smoker kind of thing. So these patients are, and we have found EGFR and ALK or other mutations also in these patients. So
Thank you, Dr. Maushmi. So as a clinician, what I want to know is like, what if you find, I mean, even though it's rare, but what if you find a common mutation like an exon 19 deletion in a histology where you don't expect it to find? So what is the implication of that, Dr. Amit? If you find a very common, well-established mutation, what is there in adenocarcinoma in some other histology, as clinicians, would you advise us to act on it, or when you look up whether the mutation is significant or not on maybe your ClinVar or in your database, does the database wants you to put in what was the histology before you go into the molecule?
No, I mean, with the changing paradigm and with the changing paradigm and with the times, it's more based on the molecular alterations.
So it's tumor agnostic. So like we have BRAF, anywhere is a BRAF.
Not right? All the, there are different kind of like alterations, as what is said, even emerging evidences suggest that also for the BRAF V600E, there are other different kind of like fusion events in or where they are completely tissue agnostic. However, context do play a major role. Context and many of these responses are context dependent and context restricted. But where are we talking about? We are talking about a setting where there is no alternative treatment or an option which is available. And in case there is nothing and no,
but sometimes it's not like that. Like for example, this lady, she's almost treatment naive. We can do anything for her. Like we could even give her metronomic.
So this is a tissue biopsy or this is a liquid biopsy?
It's a tissue from that. Okay.
I have another question. So she's been labeled as mucoepidermoid. So wasn't any IHC or anything done on her? Like,
yeah, so I think I'm not put up that report, but this patient behaved like a mucoepidermoid in the sense she had the biopsy was scanty because it was, and then there were some IHCs. I'm sorry, I don't have it here, but so even my question is, so what we're suggesting is, should we actually even go back and ask the pathologist, hey, is it actually mucoepidermoid? Does the presence of this exon 19 deletion makes it adenocarcinoma? Are we right thinking that way?
Yes, I think this could have been sorted. If I think there may be the deficiency of tissue that might have not led to IHC, but usually when the diagnosis is made, this thing is sorted. At least a minimum IHC of TTF1 or P40 or P63 is done. So that is sorted. And usually we don't have such a differential of mucoepidermoid versus a lung adenocarcinoma. That's the usual thing.
Sure.
Because the recent findings is some of the characterization before the start of the treatment, like how rightly you said, tumor board. Once the results come, then the proper discussion involving the lab will be a right approach in order to take this. Because even if there is at the interpretation level, we might ask what are the other tests done also, because that makes us in terms of the diagnostic accuracy from the NGS side, and also if we are using any other complementary tests and all. Correct.
So one thing that I wanted to just point out is like there is also important to have like the technical soundness of the data and the interpretation of it. What we are trying to do over here is like we're trying to set aside something here, because it is in the first line, something which is evidence-based, and setting aside the evidence-based and targeting, harping on to something for which there is absolutely no evidence as such existing. So here in this case, looking at the technical aspect of it, that here the VAF, that is the variant allele frequency, is 1%. 1% in a disease where it is not approved. This is more on the borderline case, more on a case where this likely could as well be a false positive, given that the VAF is so low, as what Dr. Mehta said, that in their case, they wouldn't even report, which is something which is below than 5% of a variant allele frequency. Yeah. So here it has been reported. So just because it has been reported, it is more of the something of deliberation at the tumor molecular board. Just because the mutation is present, that does not mean that to change the standard line of treatment and to jump on to the
Yeah,
target.
so that again brings, this is a common scenario. So, but then on the other hand, this report was out and the molecular pathology. So Anuradha ma'am, I'm sure a lot of these reports come to you to Tata for discussion. So what's the best way to go about it? I mean, do you ask
So-
them to send the file to you
so-
or?
Yes, as Amit rightly pointed out, with this low VAF, there all the cases have been discussed in the molecular tumor board and the collective decision has been taken. So nowadays that has really helped us for the treatment
True
decision.
So Bhavesh, finally, are you going to give TKI or chemotherapy?
So I think if we have something with the report, very difficult to convince patient that I'm not going to give anything. So I would actually try to give some targeted therapy in clinic.
Right.
If I have some target, I'll try to attack it.
Right. Okay. So that
Can I
is-
I
intervene?
wouldn't
here?
completely kill it. I wouldn't completely, I mean, this should be there, I mean, with the information, but keep this in the mind that this could be the second line, or this could be at later on with time, this variant allele frequency may go up. And
Correct.
perhaps there, the response rate as well, a concomitant response rate could as well kind of like go up. So-
Yes.
I feel I would like to repeat the test, because even if it is there is something wrong with the test, because 1% I have never seen, I don't accept it. So I think just repeat the test. Don't trust it.
I mean, I knew it will create a lot of controversy, so that's why I'm.
And that's why you get the case.
Yes.
Yeah. So I think in such case, we have to review the pathology. So first is a TTF1. If TTF1 is positive in this case, this is straight away adenocarcinoma. You rule out a salivary gland type of tumor. And another thing is tumor percentage. If it is a very tiny, I mean, very less tumor percentage, they have written more than 10%. But if we know, like if it is 80-90% tumor and then you have a 1% VAF, then maybe you can disregard it. But if to start with bronchial biopsies, usually you have very scanty tissue. In that, even if 10 to 15% tumor tissue and 1% VAF is, if no other tumor, I mean, alternative option, TKI may be considered, is what I feel.
Dr. Amit also had a point.
Do a liquid biopsy. Okay, if you can't repeat the tissue biopsy, I would suggest test it again, confirm it. I am not sure. 1%, even if the tumor is less, I don't think it will come.
So I missed it. It's a metastatic disease.
No, it's not metastatic, but it's
Then
unresectable.
what is the question? Why we
She's
want
a
to
lady is
change?
frail and she
Then just
she
go
wanted
straight
to
away
avoid
with-
systemic therapy.
Then
She,
just try TKI and see the response. What's the
Right.
harm?
so
you
that's
have a
like that's
clinical
a
scenario,
clinician's way
actually.
of doing it. So
yeah.
sometimes we even do that even without all these tests. So yes.
So just saying that we do a ISC and TTF1 positive and we say it's a lung adenocarcinoma with VAF of 1%.
So
What to do?
what does it mean? What does it mean? Yes, to the molecular pathologist. What does 5% mean? What does 20% mean?
Yeah, but
So-
we need to look whether it's a canonical or a non-canonical mutation. So like for EGFR with 80% tumor content and if 1%
So I
VAF
also
is
think like
present.
him. So if only
And I think we
1%
should,
tumors have
consider
this,
that
only 1% will respond to the TKI. What about the other 99%? Right. Right. Sure.
Just
So-
to add, the VAF, either a variant allele frequency or a minor allele frequency is a bioinformatics estimate. So with regard to you need to corroborate that with either there is a tumor mutational burden for that and all. So that way, 1% here, when the Professor Amit said, is in the way saying that whether the efficacy in the future, if we based on this particular deletion, we make a decision to go ahead with the treatment. So the treatment efficacy is what makes the difference for means lower confidence interval for the 1%. Yeah.
Sure. And to add to that, I think, I mean, this is just an example of the kind of exon 20 mutations, deletions. We had an excellent talk by Dr. Anu, she's not around. And she showed us that, I mean, it's not only about the mutation, but it's also just recently we saw like with this drug poisotinib, whether it's a closed loop, far loop, and so it's like, it's even if you have an exon 20 insertion, me and Bhavesh will jump up with joy and say, we have got a mutation. And then they'll say, no, this is actually a far loop mutation. and the forest and the waterfall plot doesn't look that great. So how is it possible in today's day and age to kind of have that level of interaction between the lab and the clinician?
Definitely, I mean, this is a challenge. I mean, this is a challenge, and that's why you specifically and particularly require a multidisciplinary tumor boards, where people from different expertise, from different background, they come together, they understand, and they deliberate upon the question. I mean, it is seemingly not possible at all or not feasible at all, and unfair to expect that medical oncologist would know nitty-gritties and the details of it.
So
That is
Bhavesh,
absolutely not something
Bhavesh,
that
if you
should
have
be
a
expected.
patient with exon 20 far loop mutation, would you use poziotinib in which line of treatment?
Maybe I think after
And
I
you have this
exhaust-
information on day one. I mean, so would you?
So I know that the water plot is not very impressive. So probably I'll go with chemotherapy, which I know that it is going to act. And
Immunotherapy?
I may keep it, chemotherapy, what I meant. And later, maybe if I have exhausted the lines of chemotherapy.
So
and
which
it's not
line? As
working-
Kumar sir was saying, there is 6 lines,
Beyond-
7th line.
So beyond at least 2 lines, because I think most of the patients are able to go at least up to the 2nd line, at least half of them. And beyond that, if patient is still surviving and has the disease,
So Dr. Amit,
maybe
you
I
have a
will
lot of
try that.
experience with serial checking, monitoring, biopsies. So would you act on these mutations in the 3rd line, 4th line, or you would insist on a repeat biopsy? If we have like a far loop exon 20 VAF of 10%
So we know
baseline.
that poziotinib is not a good drug to choose. So in that case, poziotinib is also not available in India, if I'm not wrong, because I have never tried. It's not that easy a drug to tolerate. So poziotinib is not my choice. But in this case, we could have given osimertinib. There is one which is easily doable. But again, so your question was that will
My
you
question
repeat
was
the
like,
biopsy? Repeat
yeah,
the biopsy?
would you act on an NGS which was done on a biopsy many months or years ago, and patient has had 2 or 3 lines of treatment after that?
Okay, so this is a very good question. So if the patient had a driver mutation and you have not used target therapy, the driver mutation will be the same one. Then in my experience, and also the literature says that there won't be any clonal subclones which are going to develop, which will be resistant, because it's just the chemotherapy what you have used. Had it been if you have used the target therapy, then you should do a repeat biopsy to see what new clones have developed and which you have to address now.
Sure. So repeat
yeah.
biopsy. I mean, there's so much to discuss. We don't have time.
I'd like to add something that also depends on how the patient is progressing. If I have a report of the previous year and the patient is really bad, the clinical scenario has changed, then I would want a new one.
Yes. So Bhavesh, we'll just touch upon that. So this is a patient who, the first picture I showed you, had an exon 19 deletion, received osimertinib, and right now you see this current PET, everything is responded, and she's got a solitary progression of the lesion in the right upper lobe. So in this situation, your options are repeat tissue biopsy, repeat liquid biopsy, or no biopsy, and just go ahead and add chemotherapy or radiation therapy.
So if it is in what I would consider this as an oligo progression, because PET scan does not show anything else, I would try to continue osimertinib and try to give local treatment there.
Yes, so that's what most of us clinicians would do, and that's what was done for this patient. And this, yes.
Just back to differ, because 17 months of disease-free interval, what you have got with osimertinib, it's a time that the patient will develop the secondary mutations.
Correct.
So you
So
have
that
to
is
investigate.
what I was trying to bring
Yeah,
up.
yeah.
There will be half clinicians would do a biopsy and will have a report full of mutations, and that's what I was trying to highlight in this slide. And then there will be another half of clinicians which they will say, I will use my surgeons, my radiation colleagues, and I don't care what resistant mechanism is. And we will just think about it when time comes, right? So we really don't know which is the correct approach, and patients also come in here. Some patients will say, I don't want to do a biopsy.
So regarding the osimertinib case, it's a good question, because you are going to give osimertinib beyond progression. It's a cost involved. It's better whether it is going to work or not. You should be double sure.
Correct.
That is the advantage. That is why I want to know more about it.
Correct. So this patient anyway was not my patient, so anyway, was treated with radiation, and then later on you see there's a disease in the abdomen. Bhavesh, here you will want to do a biopsy, yes? correct?
Maybe it is out of the
Yeah,
lung.
so now
probably.
I'm not listening to you. I listened to Dr. Amit, and we have done a biopsy. Okay, so we've done a biopsy, and then biopsy shows it makes small cell histological components. So now this again brings us to the importance of Radha ma'am having a tissue before you look at the NGS. If we had not done this biopsy, would you have would any of the tests would have predicted a small cell transformation?
I think.
So what is
Yes.
that little bit?
RV, yeah.
Right. So you're saying those mutations would not be present baseline; they would evolve.
Yeah.
P53.
Other than acquired risk. So we can go
Okay,
for the
actually,
repeat biopsy.
Can I add?
Yes, ma'am. Yes.
We're usually doing NGS in most of the cases. We have a custom-made panel, and the patients who are having TP53 and RB1 mutation, especially at the beginning, and initially maybe they were adenocarcinoma. You later on see the second biopsy, the small cell transformation has occurred. So there may be sense of doing an initial biopsy. You will know which patients are likely to be more aggressive or progress into something else. And small cell change cannot be picked up by any NGS. You will need a histological diagnosis for that.
Correct. And we know that a fraction of patients have small cell transformation because because this is a relatively common disease. We have these serial biopsy studies, and we are aware. What about rarer cancers? We don't have such information, right? I'm sure there are a lot of other rare cancers which are transforming, and we don't know because we don't have such kind of series. So that again just highlighting to kind of try get a tissue as much as possible, even though I think I'll see everybody's moving towards liquid biopsies and with the cost coming down. So Dr. Bhavesh, now there is small cell. What if this also had that C797S, what is responsible to which may respond to erlotinib, right? That's one of the common mutations. So sometimes you have these various things, and how do you choose now? And we don't have head-on trials.
So I think I would go by both the information what I have. If the patient is fit, probably I would try to combine. But if patient is not fit, probably go by only the targeted agent.
Sure.
Yeah. Can I add something? I want to add something. You said that the patient has C797S mutation. So there is another very important point which has to be noted if you're planning to add erlotinib, that the mutation is cis or trans to T790M. So, okay, if it is on the same allele, then it may not make sense. But if it is trans, then it makes sense to have osimertinib and erlotinib together. So that information is very important, which has to be provided in the report if somebody is reporting C797S.
Now coming to the kind of situation Dr. Amit usually has, and you have to combine. So now suppose the patient is well read and says, "Doctor, I have read immunotherapy improves overall survival in small cell cancer. I want to take immunotherapy." What do you do with the TKI part of the treatment? Okay, so you will say no. Okay, you will say immunotherapy, but you will stop all the TKI. You will stop all the TKI. Bhavesh, agree?
I may not do that in clinic.
No, and then we read about case reports of ILDs in patients who are again given TKIs after immunotherapy. So all sorts of things. So I would say that I don't think anybody can make the best decision. We all will go wrong many times.
Stopping a TKI always has to be based on a molecular evidence. And as what Moshmez just said, if you have that information that whether these two mutations, the C792S is cis or trans, along with the your exon, along with the T790M mutations, or so unless if you have that information, definitely leave aside the TKI and then moving on. But if that information is that it is trans and there are different clone of cells having different mutations, then continuing with the TKI or setting it aside would not be a very prudent decision without having this information. So that's what I would have.
So if you have this heterogeneous disease, when you have adenocarcinoma and small cell transformation, it is not 100% transformation among the two histologies, which is the aggressive one, small cell. So treat the patient with small cell dominantly, and then you take it off after maybe after 3 months, evaluate. If the small cell component is gone, you go back to your TCAS.
Sure. So
Why not?
sometimes I think so there's a clash between what the clinician feels, his gut feeling and his experience versus what the ClinVar or the recommendation is for that particular mutation.
Can I?
And, yes.
Can I add one thing? Yeah, can Dr. Ashish, I want to add one thing. So look, when we biopsy, we just have to be lucky to find the small cell component. Okay, it's just a biopsy. You may actually be a combined tumor with small cell and adenocarcinoma, but you just picked up adenocarcinoma, or like you picked up small cell, and then you on molecular profiling you have a del 19 or L858R mutation. So that is a possibility. You just have to be lucky. So how will you treat that patient? So how do you know? We just go by the molecular this thing, and if clinically also the patient is not fitting into that.
Yeah, and a lot of the time, actually, suppose this patient progress only in the brain and we don't have a tissue. And in that situation, I mean, how we hardly do brain biopsies unless there's one lesion or 2-3 lesions. So that's always the challenge. And then what Dr. Amit says that if we don't pick it up on a biopsy, none of us know about it. Nobody will ever think of etoposide and immunotherapy in this disease. Yes.
As Dr. Amit was saying, he asked of the colleges what percentage they know what percentage is small cell. Sometimes we get an answer, it's a small tissue. We cannot in the other tumor heterogeneous.
And if you bug your pathologist too much, then he will not even take your call after that. Yes, so you're talking about tumor heterogeneity, and we always know that that's always going to be the case between the primary, between the metastasis, within the same tumor over a period of time. So I would say, I think ultimately is the patient's luck that the doctor knows what he has.
So with this scenario of small cell transformation, so whatever we have seen in our molecular tumor board is that no matter what is the component of adeno or what is the VAF of any of this EGFR, mutations, if it is a small cell transformation, they treat it with small cell without adding any EGFR TKI. And because for that matter, even in treatment naive, if it is to start with mixed adeno with small cell, still the treatment is directed to small cell.
Again, so because we know that's an aggressive disease going to kill your patient within a year, we want that control first before we think anything else. Okay, so I think we are way past our time. I had 3-4 more cases, but maybe in next meeting we will discuss that.
So this might not be totally accurate, but today that I have a patient who has adeno in a lung biopsy, but when we did adeno in the fluent region, it was studied for 1 year, but the biopsy from the lung is small cell. And the TDF1 may be positive in small cell, also in fusion. So how to differentiate whether that TDF1 is due to small cell or due to adeno?
So all small cell of lung have TTF1 positivity, most of it. So when you see like crushed cells, lot of crushing, you have to put a neuroendocrine marker, which is very difficult in pleural effusion sometimes, but you still see very high NC ratio and lot of poor preservation. So that time with TTF1, please do add neuroendocrine markers, and then only you will be able to pick it up.
Was positive moderately, but we did a lung biopsy, it is clearly adenocarcinoma.
Clear? You mean there is no small cell component?
In lung, there is no small cell. Pleural effusion is, they said BK1 positive, CD56 positive, this is small cell.
No. So when you have a query, CD56 can also come in carcinomas. It is not a alone standalone marker for neuroendocrine. So what we do is we put a cytokeratin and we put neuroendocrine. So in small cell, the cytokeratin have a typical dot membranous, which we see in carcinoma. So that is a very good point to differentiate. No. So you. No. When you cannot call it small. Yes, yes.
Sure. So thank you, everyone. We have another workshop the same, so we can't encroach upon their time. So we will definitely continue this.
Thank you so much. I hope you all have enjoyed this academic feast, and sorry for the late lunch for you all. Thank you so much.